Hello, my name is Dr. Ashley Scott. I'm an anaesthetic registrar in the northeast of England. This project was undertaken with Dr. James Prentis, an anaesthetic consultant at the Freeman Hospital, Newcastle upon Tyne, UK. Preoperative anemia affects 30% of the UK population and is a common issue globally. The most common etiology is iron deficiency, though many pathologies exist, and it's well recognised that both anemia and transfusion are associated with increased perioperative complications, including postoperative infection, increased postoperative mortality, and that's only naming two. UK guidelines recommend IV iron as a treatment for iron deficiency and for functional iron deficiency anemia, though even these guidelines recognise that the evidence for this in the perioperative setting is poor. In 2020, the Prevent randomised controlled trial made waves in this area when they compared IV iron versus placebo for the treatment of preoperative anemia, and they found that no major benefit was found when IV iron was given, and that included looking at transfusion rates or even a rise in haemoglobin. And this led many of us to question our practice, though it must be said that there have been concerns voiced about the study, and of particular concern were the inclusion criteria. Patients didn't need to be iron deficient to receive IV iron, for example. In our institution, we've previously looked at our population's response to IV iron and found that they appeared to respond well. And we decided to look at the last 4 years' worth of data to see if we should change our practice based on this and on the Prevent study. So between 2016 and 2020, 99 patients had a pre-assessment and a day of surgery haemoglobin documented. When we looked at all patients together, there was an average haemoglobin rise of 137 grams per litre following IV iron in pre-assessment. Although haemoglobin was not significantly different, when patients were compared based on ferritin levels, shown here, you can see the haemoglobin levels are roughly the same, and this was not statistically significant. Patients with a ferritin less than 30 had a threefold increase in haemoglobin when they were compared with patients who had a ferritin greater than 30, and this was highly statistically significant. When patients had a ferritin of greater than 100, there was an insignificant response to IV iron. Transfusion rates also increased as ferritin levels increased, although this wasn't statistically significant. From this, we concluded that although Prevent made us question our practice, if we target the correct population, we should see an appropriate response to IV iron and hopefully an improvement in patient-centric outcomes. We think further work is required in those with borderline ferritin levels to determine whether they may benefit from IV iron, and furthermore, as other measures of iron stores, such as transferrin saturations, did not influence response to IV iron, we were able to remove these investigations from our pathway and reduce cost. Thank you.